Hi everyone, my name is Michael, and together with my research team, this is our project on the acute coronary syndromes in northern Saskatchewan, an overview of clinical characteristics and outcomes. So the background for this project is that nowadays the treatment for a heart attack is quite effective. The problem, however, is that there are still gaps and residual cardiovascular risks that need to be treated. So that's where this project comes into play. We built a prospective database of patients presenting with heart attacks to Royal University Hospital. And so this hospital is servicing all of northern Saskatchewan. And what we wanted to do then is examine these patients and see what their clinical traits and outcomes are like. Our goals were to determine, well, first off, what does the typical northern Saskatchewan heart attack patient look like? And secondly, we wanted to look at how might we implement changes at the systemic and patient level to mitigate some of those cardiovascular risks and prevent future heart attacks. So these are some key findings that I want to emphasize today. So we've taken all those heart attacks and we've broken them down in terms of ST elevation myocardial infarction, or STEMI, and NSTEMI/UA, non-ST elevation myocardial infarction, unstable angina. And the first thing I want to emphasize is more than half of these patients are presenting from a rural site. Next, if we look at the risk factors of the typical northern Saskatchewan heart attack patient, we see that chronic disease is very prevalent, both high blood pressure and diabetes. Okay, the other very common thing is smoking status. Next, if we look at the clinical characteristics of these patients, we see that the STEMI patients are presenting much more severely. There's a much higher incidence of cardiogenic shock and cardiac arrest. Also, these patients' heart function on presentation is quite lower. They also have a higher incidence of in-hospital mortality. If you look at the management of, in general, how these heart attacks are managed, most of them are getting a stent, but then they're getting discharged on a big list of medications. Nevertheless, they still have 9% mortality at the 12-month period, so we need to better treat these patients. So, where we think we might need to affect change is starting at the chronic disease management level. Clearly, chronic disease is a very prevalent risk factor, and there needs to be more patient education on how to better manage these conditions. Next up is looking at promoting a healthy lifestyle, because smoking cessation would invariably have an important effect at mitigating some of these risks, but as well, exercise and diet would also help. Again, about half of these patients are presenting from a rural site. In turn, it would be incredibly beneficial if we would have increased resource allocation for those sites so that we could decrease the time from symptom onset to medical treatment, and hopefully allow those rural sites to provide treatment of their own instead of traveling several hours to get to Saskatoon. Lastly, again, these patients have a laundry list of medications that they're being discharged with, and therefore it's imperative that we have affordable pharmacare so that these patients can take all their medications as prescribed, and those changes should help mitigate some of that cardiac risk. We're still in the data collection phase of this process. We want to continue collecting data to see, why is there such a difference in the clinical severity of STEMI patients, and whether or not the NSTEMI UA patients have a similar kind of catching up effect. To conclude, though, we'd just like to thank the Royal University Hospital Foundation and the College of Medicine at the U of S for their kind funding. Thank you.